Thank you for joining us for conversations and updates in gastric and GE junction cancer. This program is titled Practice Changing Expert Insights to Improve Outcomes for second-line treatment of gastric and GE junction cancers. And we're going to be talking about emerging therapies and new biomarkers, which is thankfully something we do have a lot to talk about. I'm Sam Klempner. I'm a GI medical oncologist at MGH in Boston, and I'm joined by my colleagues, Drs. Yelena Janjigian and Dr. Manish Shah. So I'm going to breeze through the background. I think it's pretty clear that there's still a lot of unmet need, and large genomic landscaping publications have sort of highlighted some subgroups that may be worthy of further exploration. I'm going to focus this a little bit on some of the more later developed agents, such as Claudin 18.2 and FGFR2, which maybe in the clinic in the relatively near future we'll see. But throughout all these segments, I think, although we are making steps, there's a lot of other areas to explore and worth exploring, certainly beyond the scope of this 15-minute segment. Broadly, I think our approaches can be divided into sort of targeting cell surface antigens, intracellular pathways, immunotherapies, and cellular therapies. And maybe we'll talk a little bit about some of these approaches. So I'm going to start with Dr. Shah because we recently saw this publication of the FIGHT trial. Maybe you can tell us a little bit about FGFR2b and sort of prevalence and what we've seen so far with this emerging biomarker.
Yeah, so this was an important study that targeted FGFR2 amplification, the rate of positivity for this is not so high. We had actually a similar trial open and didn't find that many patients, but I believe the rate is less than 20% overall for that carry this. But the patients who were randomized to receive the target agent actually had a better PFS. This is a randomized phase 2 study that was recently presented and published. So I think based on that, this is really an exciting target that we need to explore further. I think it highlights. I mean, we mentioned this earlier in other segments that beginning about 10 or 12 years ago with the validation of targeted therapy for targeting HER2, I think there have been a series of other drugs that have been looked at for targeting different aspects of gastric cancer. FGFR2b is one of them, and then also as I think you'll mention is the Claudin 18.2 targets as well.
Yeah, I think the FIGHT data was great to see, and we're certainly waiting the phase 3 trials that are ongoing. I think it's as you suggested, the amplification rate may be relatively low, but maybe there's capturing some people by protein expression that may additionally benefit. So we'll see, and I think it's also an important just biomarker lesson to note that consider in parallel to the PD-L1 story, the highest expressing biomarker subsets seem to have even better outcomes with some of these more targeted therapies. So I completely agree with you. FGFR2 certainly one to watch. Dr. Janjigian, I'm going to ask you to talk a little bit about Claudin 18.2 and sort of what your thoughts about this target on and sort of the trials that are ongoing and that we're waiting to see.
Yeah, so Claudin 18.2 has been an important IHC biomarker to watch out for. It's about a third of the patients in a clinic will express it in their tumor, and it shouldn't be only tested in diffuse gastric cancer because that's probably one of the things often comes up because in TCGA Claudin rearrangements were seen preferentially and genomically stable, but this is different. We're looking at immunohistochemistry, and really it's a cell adhesion molecule, and really can happen in intestinal gastric or diffuse or mixed, sort of poorly differentiated. So if it comes to the clinic, it really should be done reflexively. It's not in the clinic. That's another very common question I get from colleagues and patients is like, how do I get 18.2 testing? You shouldn't, because whatever you're going to get in the clinic will mean nothing, because for each clinical trial, there are different cutoffs, different antibodies, and you will just be wasting your tissue by doing it by some other non-CLIA approved method that your pathologist is nice enough to do. We have first-line studies looking at combination of chemotherapy plus zolbetuximab, which that study is pretty much done, and we'll be reading out very soon. And then, of course, building on KEYNOTE-811 data, everyone's now combining everything with immunotherapy. Doesn't mean that it's, the dual Claudin plus PD-1 inhibition will be as beneficial as, for example, Claudin monotherapy plus chemotherapy, but that's something that's under development in first-line setting. The challenge with these drugs, obviously, especially in our US patients, where most of our patients are de novo stage 4 patients, in other words, they don't have a gastrectomy and then they have cancer recurrence. When they have stage 4 disease, their stomach is still very much intact and is part of their daily life. These cell adhesion molecules cause quite inhibition because they occur in normal gastric mucosa. You do have quite a bit of nausea and vomiting associated. It's a class effect from all the Claudin inhibitors, and the better the Claudin inhibitor is, or the higher the overexpression is in the primary tumor, the more the nausea that's associated with it. And so that's been the challenge with this class of drugs, where we have tricks in our clinical development portfolio to try to augment, to improve on that, but it's hard. Nausea is really hard for the patients. In second line, there's several, bispecific antibodies looking at Claudin. There's even antibody drug conjugates that are being developed. So there's this whole a rush of Claudin inhibitors in the market, and we'll just have to wait and see. I think unlike, let's say, some of our true drivers, I think it's going to be an okay biomarker. It's not going to be a perfect biomarker, and then it'll just come down to which patients are we selecting and how well tolerated the drug is. I would just add that CAR T cell therapy and that whole program in Claudin inhibitors is also robustly underway. It's in solid tumors. CAR T is definitely not prime time yet, so I wouldn't build it up too much to your patients. Even in very, very selected patient population, which are usually enrolled in these solid tumor CAR T studies, where the disease volume is very minimal, essentially. You can't even have a certain above a certain number of metastasis and measurements and so forth. The median progression-free survival is relatively short. It's usually less than 6 months, but it's an exciting area to be in just to even talk about it. And so certainly, I think in the next 5 years or so, there's going to be a lot of breakthroughs made in the CAR T realm as well.
Yeah, no, thank you for the overview. So I'm going to Dr. Shah, I'm going to ask you sort of a two-part question. So Claudin 18.2 seems to be a pretty tumor-restricted antigen. So maybe talk a little bit about how that might create a scenario for other cellular therapies or CAR T just broadly. And then perhaps more importantly, let's envision a scenario a year and a half from now where you have FGFR2b and Claudin 18.2 and PD-L1 and HER2 available to you. And you have a patient who is Claudin 18.2 and PD-L1 CPS5, and we don't have data for the Claudin plus PD-1 combination data. I know you're someone who thinks, very critically about trial design and this, and I've always enjoyed that. How are you going to be thinking through these sort of multiple biomarker overlap situations? Maybe you can answer that one, and then we can come back to the CAR T question.
Yeah, no. So great question, and thank you. I've always maintained that with more options, we have more flexibility in terms of positioning the drugs for our patients. And I always think of kind of likely where would we get the most benefit, the least toxicity, and then what are the next options, if that option fails. As Dr. Janjigian mentioned, Claudin 18.2 seems to be and you mentioned as well, a tumor-restricted biomarker. It's like in the gap junction, and as a tumor differentiates, it kind of is exposed. That being said, there is a fair amount of toxicity with nausea and vomiting with the drug. We don't have the results of the phase 3 data. We know for CPS5 that we can expect, a significant improvement in survival adding nivolumab to chemotherapy. And I think what we don't have enough data on is predicting who the long-term, the tail on the curve, who are the long-term survivors. So what I'm really saying is that once we have the data for the GLOW or SPOTLIGHT studies, these are the first-line studies with Claudin 18.2, and we'll get a sense of the activity, how much better it is over chemotherapy, and then what the tail on the curve is there as well. That may help us to kind of, try to line up what lines of therapy, what options we can use for our patients. And I think the other part of it is, and we do this all the time, at least in colon cancer, you have to kind of match the toxicity to the patient as well. The oxaliplatin is very active in the first line setting. But in colon cancer, irinotecan has equal activity. And so if someone has, uses their hands, that needs the dexterity for whatever reason, they may be a surgeon or whatever, you may consider your options in that context. So having more options allows us to give better individualized care. But I think, the question you really asked, which I'm probably sidestepping, is how would I choose one over the other? And without having much data, you have to kind of do your own cross-trial comparison, which they tell us not to do.
Yeah, I think, we're probably going to have a lot more conversations like this in the future, where we sort of do try to just talk it out and assess the hazard ratios and relative magnitude of benefits across these studies. I completely agree. Maybe in the last couple minutes, I'll just go back and forth between the two of you and ask, in addition to FGFR2 and Claudin 18.2, which are probably the most advanced right now, maybe what are your top 3 other biomarkers to watch? We certainly have seen, VEGF plus IO combinations with LEAP-15 kind of coming on the background, but I'll start with you, Dr. Janjigian. What are sort of your top 3 other biomarkers to watch?
Yeah, so I just wonder, because we've been here with EGFR and MET, right, in a similar situation where people were really excited about those biomarkers. And unfortunately, the phase 2 data and translation into phase 3 didn't hold up. I wonder if now that we're a bit better at selecting patients and know more about other factors, that if we go back and try to resurrect EGFR and MET in a more constructive way with better bispecifics or better patient selection or both, it's great, because our patients are living longer and longer, and we're now getting more sophisticated at selecting patients who will be on that tail end of the curve. And then perhaps we need to focus on lifting those patients up further. And, patients always ask me, will I be cured? Can you cure me? And my definition of cure is, if you're alive and here 5-10 years later with stage 4 disease. So I think we have an opportunity there for some of the traditional biomarkers that may be not as, sexy as CAR T cell therapy, but there is still some room to maneuver there with bispecifics and other better inhibitors and better patient selection.
All right, and Dr. Shah, your sort of things you're watching.
Yeah, so I'm drawn by the promise of immunotherapy and overcoming that. I think that in a relatively small subset, we have long-term survival that's really transformative for our patients' lives. And so I think that we can improve immunotherapy with other combinations and things like that. So the CAR T Claudin 18.2 study that was recently published. I think, even though the duration of response was low, as was mentioned, for me, it is a proof of concept. We did get a 30 to 40% response rate in that population. HER2 CAR T therapies being developed. I think that we could think about off-the-shelf NK CAR T or CAR therapies as well. So I think that's one area. And then modulation of the immune microenvironment is another area that I think has a lot of promise in the right context. It's clear that each of us are going to be very busy over the next decade, I'm sure.
Yeah, I completely agree. For me, I'd say DKK1 and DKN-01 has been an interest. It may well be a macrophage repolarizing agent and primarily working at the TME. I think mining the surface proteome and things like TROP2 and some of these other targets are of interest to me as well. But I really just want to thank the both of you. Thanks for joining us for this segment on emerging therapies and biomarkers in gastric and GE junction cancers. Please be sure to click on the landing page for this activity and claim your AMA, ANCC, or ACPE credit. You can see the supplemental slides and other topic segments and case presentations.